chemotherapy. We can give ondansetron, granisetron. These are the first line. Then we can add neurokinin receptor inhibitor like apritenin. We can use, even steroid can be given. Dexamethasone can be given. There are other form of drugs. I totally forgot. Hello? Yes. Okay. Uh, okay. These patients lab values are relative. These patients lab value are relatively unremarkable, aside from mild anemia and thrombocytopenia. Two common findings in patients with lymphoproliferative disorders on chemotherapy is her symptoms of vomiting and malaise are likely. Her symptoms of vomiting and malaise are likely side effects of the chemotherapy in the setting of normal lipase level. In the setting of normal lipase level, an abdominal examination without rebound or guarding, and a bowel movement, yesterday. Other diagnoses such as pancreatitis, perforation, or bowel obstruction are less likely. The presence of dry mucous membrane suggests mild volume depletion due to vomiting. Therefore, IV fluid administration is a good first step in patient's management. The subsequent step would be treat. The subsequent step would be to treat her nausea and the vomiting. Serotonin receptor antagonist ondansetron that target the 5-HT3 receptor are considered the first line treatment for chemotherapy induced nausea. They have low side effect profile and highly efficacious. These medications can be used to manage acute emesis but are useful for prophylaxis, sometimes in combination with corticosteroid. Okay. He's taking lots of cow's milk, like over 700 ml of cow's milk can cause iron deficiency anemia. Okay, RDW, increased red cell distribution. What? Isn't it 700 or how many? Okay, I'm reading. Okay, so these patients microcytic anemia and excessive cow's milk intake. These patients microcytic anemia and excessive cow's milk intake are concerning for IDA. Cow's milk has a low iron content. Cow's milk has a low iron content. In addition, the bioavailability of the iron is poor. In addition, bioavailability of the iron is poor because the calcium and the casinophosphatide found in cow's milk interfere with the intestinal absorption of the dietary iron. Also consuming large volume of cow's milk, also consuming large volume of cow's milk replace the normal intake of iron rich food. For this reason, children who consume more than uh, oz 24 hours per day are especially at risk of IDA. Although severe IDA can impair neurocognitive development, most children are asymptomatic. Most children are asymptomatic and have age-appropriate skill as seen in this patient. Tachycardia and a flow murmur may be present because cardiac output increase to compensate for reduced oxygen carrying capacity of iron deficient red blood cell. Inadequate iron store in the bone marrow lead to low erythrocyte count and the production of hypochromic RBC with low MCV, low mean corpuscular volume. However, RDW red cell distribution width is elevated because the amount of the RDW red cell RBC distribution width size variability is elevated because the amount of iron available for RBC synthesis varies throughout the day. Platelet count is platelet is very low. Platelet is low. Oh, sorry, fibrinogen normal. PT is raised. Catradicanosis. Hmm. It's not von Willebrand. Von Willebrand has PTT. Decrease ADAM-TS13 is TTP, thrombotic thrombocytopenic purpura. It is not. And block the production of the thromboxane A2. It is the NSAIDs mechanism or aspirin mechanism. Bone marrow infiltration. Is it ITP? Is it platelet autoantibody? Okay. So, okay. This patient has bleeding episodes and isolated thrombocytopenia due to immune isolated thrombocytopenia likely due to ITP. ITP is an autoimmune disorder in which IgG antibody against the platelet membrane glycoprotein causes increased platelet dysfunction. Uh, IgG antibody against platelet membrane of the glycoprotein cause increased platelet destruction and inhibition of the platelet production. Presenta- Presentation is most common in healthy children aged 2 to 5 or adolescent with petechiae, chymosis, and mucosal bleeding. Other than bruising or physical examination, can you take give me a 1 or 2 minute? I don't know. I am talking. Okay. Okay. Next, or you want me to read this question? Yes, it is in between two. I am looking for your opsoclonus myoclonus syndrome. Yes. So when patient cries, her left side of the face is flushed. What does it mean? It's maybe periorbital ecchymosis. Okay. Okay. This patient has Horner syndrome in the setting of cervical paravertebral mass. This patient has Horner syndrome in the setting of cervical paravertebral mass. Finding suspicious for neuroblastoma. Neuroblastoma is a type of neuroblastoma is a common extracranial tumor of the childhood with mean age less than 2. The tumor arises from the neural crest, which are precursor to the sympathetic ganglia and the adrenal medulla, the latter of which are most common sites of neuroblastoma. Tumor involvement of the Tumor involvement of the cervical paravertebral sympathetic chain can lead to tumor involvement of the cervical paravertebral sympathetic chain can lead to ipsilateral Horner syndrome, ptosis, meiosis, and hydrosis. Although swelling is often difficult to appreciate in young children, absent facial flushing, Harlequin sign can be observed in anhydrotic areas, as seen in this patient. Flushing can be observed also. Okay. Urine and serum catecholamine, vinyl mandelic acid, and homovalenic acid are elevated in the majority of the patient. Tissue biopsy is required for definitive diagnosis. And medulloblastoma and pilocytic astroma are childhood brain tumor that commonly arises in the cerebellum. Presentation typically involves ataxia and dysmetria, not Horner syndrome. Okay. Okay. It involves the sympath. It actually involves the sympathetic thing, and thus causing this Horner syndrome. When the yes. Fossils. Is it EVB? There is only the lymphocyte high. Is it drug induced SLE? Like okay, we can discontinue. Drug induced neutropenia. We haven't looked at the leukocyte. Leukocyte is very low. I actually, you are not. Leukocyte is 1800. Absolute neutrophil count. This patient with fever and pharyngitis has severe neutropenia. Fever and pharyngitis has severe neutropenia. Absolute neutrophil count is less than 500. Absolute neutrophil count is less than 500 with normal platelet and erythrocyte count. Given the recent initiation of the sulfasalazine, the most likely underlying etiology is drug-induced neutropenia. Drug-induced neutropenia. Medication trigger neutropenia due to one of the following: direct toxicity, immune-mediated destruction. Direct toxicity: the medication directly destroys the granulocyte precursor in the bone marrow. Direct toxicity is usually dose dependent and is seen most often with cytotoxic medication like clozapine and dapsone. Mm, Immune-mediated destruction: the medication or a metabolite adheres to the neutrophil surface, acts as an heptin which triggers the cytotoxic T cell or antibody response that destroys the cell. Most cases are idiopathic, not dose-dependent. Common triggers include sulfasalazine, trimethoprim, sulfamethoxazole, PTU, and flecainide. Drug-induced neutropenia presents with oropharyngeal mucosidosis, sore throat, pharyngeal edema, ulcer with or without fever. Platelet and leukocytes are commonly normal. When a patient taking medication associated with neutropenia, the most important first step is to stop the offending agent. Most cases resolve within 1 to 3 weeks. Although oropharyngeal erythema, malaise, fever, neutropenia can occur with viral infection, Epstein-Barr virus. The neutrophil nadir is usually mild. Absolute neutrophil count 500 to 1500, and the patient typically have prominent symptoms like lymphadenopathy and splenomegaly. Neutropenia is due to bacterial infection, sepsis, and is usually associated with decrease on the other cell line like anemia and thrombocytopenia. Okay. It's sickle cell pain crisis. So this patient with sickle cell disease and severely diffuse pain is likely having an acute pain episode with occlusive crisis. Patient is associated with increased risk of number of episodes, especially in the third trimester, because physiologic changes of the pregnancy increase metabolic demand, promote hemoglobin polymerization, and sickle formation. In addition, maintenance medication hydroxyurea are often stopped by patient due to fear of fetal toxicity. Hydroxyurea are often stopped by the patient due to fear of fetal toxicity. These patients severe nausea or vomiting, ketonuria, elevated amylase, transaminase is likely triggering Likely triggering factor for pain episode: the low hemoglobin, elevated reticulocyte count, and bilirubin. The low hemoglobin, elevated reticulocyte count, and bilirubin provide evidence of chronic hemolysis characteristics of sickle cell disease. Fetal hemoglobin rate deceleration are expected during a crisis due to decreased fetal oxygenation and perfusion, and resolves the patient's trimester and resolve as the patient's condition stabilizes. Treatment of a vaso-occlusive pain episode in pregnant patient is similar to that of the non-pregnant patient. IV hydration and aggressive pain control, morphine, patient control analgesia, prompt and sufficient pain control with episode is critical for relieving while its precipitating cause is treated. Okay. Okay. Pancytopenia. Elevated, sorry, enhanced cell destruction, hypersplenism or SLE. Pancytopenia, enhanced cell destruction, hypersplenism. Immunologic is SLE. Impaired cell production, bone marrow aplasia, bone marrow infiltration. Bone marrow aplasia is inherited aplastic anemia, Fanconi's anemia, and acquired aplastic anemia is idiopathic drugs and toxins, infection, HIV, EVP, radiation, immunologic, and malnutrition. Bone marrow infiltration, malignancy, storage disease, Gaucher disease. This child has pancytopenia. This child has pancytopenia, which is typically caused by increased red cell destruction. Increased this patient has pancytopenia, which is caused by increased red cell destruction, impaired cell production. In this case, the patient's bone pain and diffuse lymphadenopathy are concerning to acute lymphoblastic leukemia. In ALL, uncontrolled growth of malignant cell in the bone marrow results in impaired production of the normal cell line. bone marrow failure. Although initial symptoms of the ALL, although initial symptoms of the ALL are often non-specific, fever, poor appetite, weight loss, physical examination frequently reveals pallor and bruising or petechiae due to anemia and thrombocytopenia respectively. Leukopenia with recurrent infections can occur. However, leukocytosis often is seen due to spread of lymphoblasts from the bone marrow to the periphery. As leukemic cells proliferate and expand the bone marrow, many children develop bone pain with deep palpation, refusal to walk, affecting the long bones, femur, tibia. In addition, lymphadenopathy and hepatosplenomegaly can result from extramedullary leukemic spread. Bone marrow evaluation is diagnostic. Bone marrow evaluation is diagnostic in normal marrow blasts comprise a small percentage of cells, whereas diagnosis of the ALL is confirmed by abnormally increased lymphoblasts more than 20% on bone marrow aspirate. Yes, hemoglobin electrophoresis is diagnostic of sickle cell disease, which often cause splenomegaly in young children and can present with fever and bone pain, vaso-occlusive pain crisis in the setting of infection parvovirus. Although parvovirus can cause aplastic crisis in such patients, the complication is characterized by severe anemia, not lymphopenia or thrombocytopenia. Moreover, diffuse lymphadenopathy is not seen. Okay, sorry. Are you thinking about hemophilia? Hmm. Is it uh, is it collagen synthesis defect like vitamin C? It cannot it cause lymph. Hmm. And hepatosplenomegaly may not be, may maybe platelet. Think about different way, like a little boy hepatosplenomegaly. Don't look at the bleeding point. Think about hepatosplenomegaly in a little boy, and all the blood count are low. Okay, it is very tough. So these patients bruising non-tender lymphadenopathy, these patients bruising non-tender lymphadenopathy and hepatosplenomegaly are concerning for ALL. ALL is most common childhood cancer with peak incidence is 2 to 5. Pathogenesis of the ALL involves rap- rampant growth and overcrowding of the leukemic cells in the bone marrow. These halts the production of normal cell line. About half of patients with ALL present with bruising, petechiae, mucosal bleeding, oozing from gums, and due to impaired platelet dysfunction. Bone marrow failure also leads to pallor, fatigue from anemia, and recurrent infection from neutropenia. Non-specific symptoms, poor appetite are common. The spread of leukemic cells out of the marrow can cause liver, spleen, lymph node to enlarge. In contrast to infectious cause of lymphadenopathy, malignant nodes are typically firm, non-tender, as seen in this child. Bone marrow biopsy is diagnostic. Yes, connective tissue disorder, Ehlers-Danlos syndrome, and vitamin C deficiency may present with fragile, easily bruised skin due to impaired collagen synthesis. However, lymphadenopathy and hepatosplenomegaly would not be expected with either condition. Scurvy is also exceeding rare and unlikely to develop from a month of poor appetite. And von Willebrand factor is a protein that allows platelet adhesion. Decreased von Willebrand factor production as seen in these von Willebrand disease typically presents with minor bleeding and bleeding despite a normal platelet count. This condition would not explain this patient's lymphadenopathy and hepatosplenomegaly. Don't look at upwards, just see the lab values and you will got the answer. No, no, I'm not giving you that. Oh, sorry. Oh, in the lab, just say what are the what are in the what have you found in the labs? And so these three were as a whole: anemia, thrombocytopenia, acute kidney injury. Yes, you can say HAS, you can say TTP. Though there is no fever and neurological deficit, it is actually the scleroderma renal crisis, but these three things as a whole: anemia, thrombocytopenia, and acute kidney injury, uh, all have DICTTP has help. All of them has schistocyte helmet cell, fragmented cell. Okay. These patients marked hypertension. These these patients marked hypertension and acute kidney injury. These patients marked hypertension, acute kidney injury in the setting of systemic sclerosis. Scleroderma suggests scleroderma renal crisis, which can occur in up to 20%, with diffuse cutaneous systemic sclerosis. Scleroderma renal crisis usually occurs within the within first 5 years of SSC diagnosis. The likely mechanism involves increased vascular permeability, activation of the coagulation cascade, and increased renin secretion. Patients typically develop a sudden onset of renal failure. Patient typically develop sudden onset of renal failure without previous kidney disease and a malignant hypertension, headache, blurry vision, nausea. Urinalysis can be normal or Urinalysis can be normal or show mild proteinuria. Peripheral blood smear can show microangiopathic hemolytic anemia similar to hemolytic uremic syndrome or thrombotic thrombocytopenic purpura or DIC with fragmented red cell schistocyte and thrombocytopenia. Okay, yes. Alveoli bodies are the basophilic remnants of the nucleus that appear as small black pillets in the RBC. They are seen in patients with a history of splenectomy or functional asplenia. Alveoli Alveoli bodies are not seen in healthy individuals. Alveoli bodies are not seen in healthy individuals, and as how jolly bodies are not seen in healthy individuals, as a normal spleen efficiently removes them. Normal spleen efficiently removes them. Okay, and the sparse cell are RBC. Sparse cells are RBC with irregularly sized and spaced projection that are most commonly seen in liver disease. condition produce okay. I have got heat, but arterial throm. Okay, okay. Look at the picture. Heparin and platelet factor 4 binds with the IgG. Heparin and platelet factor 4 binds with the IgG. Heparin platelet factor 4 antibody. Heparin platelet factor 4 plus antibody immune complex plus platelet. These causes splenic macrophage to remove platelet complex plus thrombus formation, causes platelet consumption, thrombocytopenia, and platelet activation, procoagulant micropartylate release, and thus causing thrombosis. And platelet activation, platelet release causes platelet aggregation and thrombosis. This patient was initiated on low molecular weight heparin due to an acute DVD. A week later, lab studies show a significant reduction in the platelet count, suggesting type 2 heparin-induced thrombocytopenia. A drop in platelet more than 50% and a new thrombus production within 5 to 10 days of heparin initiation should raise the suspicion of heat. Heparin-induced thrombocytopenia may manifest sooner in patients previously exposed to heparin. Heparin induces a conformational change to a platelet surface, platelet factor 4, which creates a neoantigen. In patients with heat, the immune response by forming an IgG autoantibody heat antibody. Heat antibodies then coat the surface of the platelet, causing thrombocytopenia, thrombus formation. Thrombocytopenia, the reticuloendothelial system removes heat associated. Uh, the reticuloendothelial system removes heat coated platelet, causing mild to moderate thrombocytopenia, means nadir of 60,000. Severe thrombocytopenia less than 20,000 is uncommon. And thrombus heat antibodies activate platelets, resulting in platelet aggregation and the release of procoagulant factor. This puts patients at very high risk for arterial or venous thrombosis. Venous thrombosis in the leg vein and cardiac vessel and skin is common. Arterial thrombosis may occur in the heart, limbs, or central nervous system. If heat is suspected, all heparin if heat is suspected, all heparin products should be discontinued immediately, and anticoagulation should be initiated. A non-heparin medication, argatroven, fondaparinux. Diagnosis is confirmed by functional assay, serotonin release, assay gold standard, or high titer immunoassay of the blood. Okay, and it is not hematrosis. Hematrosis is usually due to trauma, vascular damage, or coagulopathy, hemophilia. It is common for heat to cause bleeding issues. Multiple myeloma does not cause IgM spike. It causes IgG sharp spike because yes, hyperviscosity and hyperviscosity and less than more than 10% of the clonal B cell. It is not present in there, but IgM for Waldenstrom M. Okay, Waldenstrom macroglobulinemia lympho is a lymphoplasmocytic malignancy characterized by excessive production of monoclonal IgM antibody. Clinical presentation of Waldenstrom macroglobulinemia stem from the elevated serum IgM, hyperviscosity syndrome, neuropathy, cryoglobulinemia, and the neoplastic infiltration of tissue, hepatosplenomegaly, lymphadenopathy, cytopenia. Peripheral blood smear may show rouleau formation and or erythrocyte agglutination due to elevated serum protein. Serum protein electrophoresis is an important screening study. Patients with Waldenstrom macroglobulinemia have an monoclonal spike of IgM. Diagnosis is then confirmed by bone marrow biopsy. More than 10% of the clonal B cell with specific cytogenetic feature. This patient presents with Walden's. These patients present with mm, these patients present with manifestation of hyperviscosity syndrome, diplopia, tinnitus, headache, dilated or segmented uh, fundoscopic finding, neuropathy, electric sensation, and evidence of infiltrative disease, hepatosplenomegaly, anemia, thrombocytopenia, suggestive of Waldenstrom macroglobulinemia. Patients with monoclonal gammopathy of undetermined significance also have M spike, but they are more commonly due to IgA, IgG, or IgD. IgG, IgA, IgG, or IgD. IgM is seen in 15% of the cases. Monoclonal gammopathy of undetermined significance is marked by smaller M spike less than 3 gram per dl and bone marrow biopsy with less than 10% of the monoclonal plasma cell. Unlike this patient, no end organ effect, no end organ effect like no anemia, hepatosplenomegaly, lymphadenopathy, or systemic symptoms. Sorry, B and C. Okay. A multiple myeloma is a plasma cell neoplasm that produces a monoclonal antibody spike by serum protein electrophoresis. However, patients with multiple myeloma rarely produce monoclonal IgM. Multiple myeloma is typically characterized by monoclonal IgG, IgA, or light chains. In addition, patients with multiple myeloma tend to present with bone pain rather than hyperviscosity, neuropathy, and tissue infiltration. Okay. or sorry, AML comes with the DIC. Age is 17. I- Isn't it ALL? I am thinking peak age is 2 to 5, but can happen, and it can come with the medicinal mass. Okay, this adolescent has intermedicinal mass. This adolescent has intermedicinal mass and associated superior vena cava syndrome, a condition in which superior vena cava obstruction leads to venous swelling of the head and neck, jugular venous distension, as well as laryngeal edema, cough, difficulty breathing. In the setting of pancytopenia and testicular enlargement, these findings are worrisome for ALL. Although most common in children, ALL in adolescent and young children is often associated with a mass of the thymic origin, intermediastinal mass that causes compressive syndrome. Extramedullary leukemic spread often Extramedullary leukemic spread commonly results in hepatosplenomegaly and may cause non-tender testicular enlargement as seen here. In addition, classic findings of bone marrow failure may be present and include fatigue or pallor from anemia, bruising caused by thrombocytopenia, recurrent infection due to neutropenia. However, white blood cell is often variable because leukocytosis can occur once leukemic cells overcrowd the bone marrow and spill into the periphery. Diagnosis of ALL is confirmed by abnormally increased lymphoblasts, more than 20% of the bone marrow aspirate. In the case of mediastinal mass, flow cytometry of the bone marrow aspirate usually reveal T lymphoblasts as the cells of the origin due to their proliferation within the thymus during lymphocyte maturation. Yes, AML can present with hepatosplenomegaly and pancytopenia. However, compared to ALL, however, compared to AML, ALL is much more likely diagnosis in children. In addition, mediastinal involvement with subsequent SBC syndrome would be unusual in AML because the thymus is the site of T lymphocyte. The thymus is the site of T lymphocyte proliferation, and testicular enlargement is not typical of AML. Okay. After giving folic acid, his hemoglobin is corrected. So what is your diagnosis? And now new symptom. It is vitamin B12 deficiency because in macrocytic anemia there are two types like vitamin B12 and folate. If you if you don't know which deficiency it is, and if you just randomly give a patient with macrocytic anemia folic acid, then his anemia will be corrected. But if he has vitamin B12 deficiency, the tingling numbness will not gonna correct it, and there is a grave complication like subacute combined degeneration of the spinal cord can happen in vitamin B12 deficiency. Okay, these patients with anemia was treated empirically for folate deficiency in the setting of heavy alcohol use. He now has a worsening neurological symptom consistent with untreated coexisting cobalamin vitamin B12 deficiency, possibly due to limited meat intake or pernicious anemia. Both folate and cobalamin vitamin B12 deficiency can result in macrocytic megaloblastic anemia. Folate supplementation is often given to patients with heavy alcohol use. Cobalamin supplementation is not routinely administered because in this patient cobalamin deficiency is rare in the absence of chronic pancreatitis. However, cobalamin deficiency can develop with limited animal protein intake, or with advanced age due to decreased intrinsic factor, pernicious anemia, and subsequent metabolism of the vitamin B12. In advanced stages, cobalamin deficiency can result in peripheral neuropathy, tingling, or posterior column defect due to defective myelin synthesis. Because folate and cobalamin are the cofactor in the conversion of the homocysteine to methionine, folate supplementation can improve the anemia. Folate supplementation can improve the anemia of cobalamin deficiency. However, because cobalamin is used in other processes as well, neurologic deficits can be precipitated or worsening when folic acid is given without cobalamin supplementation. Therefore, it is common to consider cobalamin deficiency prior to starting folic acid replacement. Okay. He is like he has hepatomegaly fatty liver and he is alcoholic. Yes, alcoholic can cause, and there is no like tingling numbness, isn't it? So, is it? Yes, it is folate. So, wait. You are talking about another thing like thiamine deficiency. Okay. Like alcoholic patient can have folate deficiency. And another important thing, why it is not folate. Sorry, why it is not thiamine. Look at the MCV. MCV is high, so it is either folate or either vitamin B12. MCV is 110, so you cannot think about mm, thiamine deficiency. Yes, thiamine, confabulation, ophthalmoplegia, memory impairment, ataxia, Wernicke-Korsakoff syndrome. These patients heavy alcohol use, pancytopenia, significant macrocytosis, likely has megaloblastic anemia due to nutritional folate deficiency. Folate is an essential dietary nutrient found in leafy vegetable and fortified grains because it has relatively limited total body store. A consumption of unbalanced or nutrient poor frequently results in folate deficiency within 5 to 10 weeks. Alcohol also directly hastens folate deficiency by reducing folate absorption in the small intestine, impairing uptake or storage in the liver, increasing urinary excretion. Although many cases are asymptomatic, patients often develop clinically significant megaloblastic anemia with macrocytosis and mild thrombocytopenia and leukopenia. Alcohol may cause hematologic abnormality such as microcytic anemia due to gastritis or bleeding varices IDA or normocytic anemia due to direct toxic effect on the bone marrow. Is it polycythemia? Hemoglobin is very high. Hematocrit is high. For 55, hemoglobin is high. Coronal proliferation of the myeloid cell. What is it? It is isn't it multiple myeloma? CML, sorry. Volume contraction or increase erythropoietin production. I think that it's plasma volume contraction, or is it EPO production? Another important thing, like he has BMI is high. Yes, EPO. It's OSA. Okay, this patient's presentation is most consistent with obstructive sleep apnea. Obesity is an strongest risk factor for OSA. Patients, not all patients have obvious respiratory symptoms, snoring, gasping for air. The sequelae of the OSA, erectile dysfunction, arterial hypertension, may be what prompts the initial evolution. In patients with OSA, recurrent collapse of the pharynx during sleep results in transient airway obstruction. These causes short episode 20 to 40 seconds. These causes short episodes 20 to 40 seconds of apnea or hypoapnea, which reduce blood oxygen level. The kidney respond to hypoxemia by increasing erythropoietin, which stimulate the bone marrow to differentiate more RBC. There is quite common for patients with OSA to have elevated hematocrit level polycythemia. The term polycythemia and erythrocytosis are often used interchangeably. Polycythemia is a lab finding of the elevated RBC count and hematocrit. Relative polycythemia is generally due to reduced plasma volume, whereas absolute polycythemia, erythrocytosis, is due to increase R, increase RBC mass, and can primary polycythemia, sorry, secondary, that is chronic hypoxia or EPO producing tumor. Okay, why it is OSA can cause OSA causing hypoxemia, transient hypoxemia, and the kidney respond to increasing erythropoietin, which can result in erythrocytosis. Okay, the last part, educational objective. So that is the main reason that hypoxia or hypoxemia causing increased EPO production, like OSA can cause hypoxia or hypoxemia and okay. Yes. Okay, normal hemoglobin is a heterotetramer composed of 4 chain, 2 alpha, 2 beta chain in children and adult, 2 alpha and 2 gamma chain in fetus and infant, fetal hemoglobin. In patients with alpha thalassemia, more than one alpha gene is deleted. When three genes are lost, a condition called hemoglobin H disease, the non-alpha chains accumulate in the homotetramer in children or adults. These homotetramer are composed of beta chains, hemoglobin H, whereas in fetus or infant they are composed of gamma chains, as seen in this patient. Hemoglobin H usually presents in infancy with chronic hemolysis due to shorter RBC lifespan and increased splenic sequestration, increased erythrocyte count, and reticulocytosis occur in the bone marrow. Bone marrow attempts to replenish hemolyzed RBC. However, RBCs are microcytic and hypochromic because hemoglobin accounts for majority of the RBC volume. Characteristics finding on peripheral smear include abundant target cell as a result of the reduced RBC volume. The presence of gamma tetramer hemoglobin bars on hemoglobin electrophoresis should raise suspicion for alpha thalassemia. It is classically associated with hydrops fetalis, the most severe form of alpha thalassemia, which is due to 4 alpha gene and typically leads to death in the utero. Yes, patients with hereditary spherocytosis have a defective RBC membrane protein that results in spherocytes. Okay, sorry. Secondary erythrocytes is characterized by an increase in immature erythrocyte polychromasia in response to hypoxia or tumor. Hemoglobin electrophoresis would not show a gamma tetramer, and iron deficiency anemia causes microcytic hypochromic anemia similar to thalassemia. However, decreased RBC production due to inadequate iron stores results in low erythrocyte count and pencil cell on peripheral smear. Okay, pencil cell. Yes, iron deficiency anemia can come with pencil cell. Yes, it is elliptocyte. It is not clearly the pencil cell. Okay, pencil cell may be in the first stage. Uh, Isn't it drug-induced hemolysis? Yes. Uh, I am. Yes. I am thinking like I am trying to rule out the G6PD. G6PD can cause hemolysis, but it is with the sulfur drugs, and it takes time to have this. Not like this patient is admitted in the hospital, is on azithromycin, and then the hemolysis starts, isn't it? So it is rapid onset, like hemolysis, like drug induced. Okay. So this patient dark color urine, elevated bilirubin, and anemia shortly after receiving antibiotic, raising strong suspicion of drug-induced hemolytic anemia. The most common triggers is NSAIDs, diclofenac, piperacillin, and cephalosporin. Although medication can trigger hemolysis through a variety of the mechanism, oxidative injury, complement-mediated hemolysis, penicillin, cephalosporin typically cause hemolysis when they bind to erythrocyte surface, uh, acting as a heptin that facilitates IgG attachment. Subsequently, the IgG coated erythrocytes are destroyed by splenic macrophage, leading to extravascular hemolysis. Medications manifestation typically arise within hours and a few days after drug administration, include signs of anemia, tachycardia, dyspnea, hemolysis, elevated bilirubin, dark colored urine. Severe hemolysis can cause back or abdominal pain due to erythrocytosis in the vertebral body, liver, spleen. Lab evaluation usually shows increased bilirubin, LDH, and reticulocytosis. Heptoglobin, which binds to free hemoglobin, will be very low. The diagnosis of the immune-mediated hemolysis is made with direct antiglobulin Coombs test, which detects the IgG and C3d on the erythrocyte surface. Withdrawal of the offending drug typically leads to resolution of the symptom within hours or days. However, blood transfusion and corticosteroid are sometimes required if they are severe cases. Okay. SLE can cause pancytopenia, yes. What are the other features you have found in the SLE? Non-painful oral ulcer, petechiae. There is oral ulcer in SLE, joint pain. Okay, maybe SLE. Sorry, is it peripheral destruction? Okay, hematologic manifestations of SLE: anemia, leukopenia, thrombocytopenia, anemia of chronic disease, SLE, nephritis, IDA, iron deficiency anemia, and immune hemolytic anemia. Uncommon is medications, MAHA, and aplastic anemia. And there is leukopenia, immune mediated destruction, medication, bone marrow dysfunction, and thrombocytopenia, immune mediated destruction, medications, TTP. These patients' presentation: joint pain, oral ulcer, hypertension. These patients' presentation: joint pain, oral ulcer, hypertension, pancytopenia, impaired renal function, suggest possible SLE, a systemic autoimmune disorder, or severe thrombocytopenia, platelet less than 50,000, manifestations with common associated features of bleeding gums and heavy menstrual period is likely due to SLE. In the US, SLE occurs most commonly in the African American, Hispanic, Asian women. Hematologic abnormalities can occur in over half of the SLE patients, include anemia, leukopenia, and thrombocytopenia. Anemia resulting from immune destruction, but also from coexisting renal disease or chronic inflammation. Leukopenia or neutropenia, often immune mediated or correlating with disease activity, and thrombocytopenia, most commonly due to immune mediated thrombocytopenia, ITP. The presence of autoantibodies. The presence of autoantibody is the primary mechanism underlying the most common pancytopenia in SLE. Thrombocytopenia is most often caused by antiplatelet antibody, which trigger increased obstruction of platelet via immunoglobulin binding in the peripheral blood vessel and subsequent macrophage phagocytosis. Less commonly, thrombocytopenia can occur in SLA-associated hypercoagulable state, in which platelets are consumed within the thrombi. Thrombotic thrombocytopenic purpura associated with schistocyte, and the DIC, which can occur in antiphospholipid antibody syndrome. Okay. Okay, this patient with mechanical aortic valve. This patient has mechanical aortic valve developed symptomatic anemia and reticulocytosis, raising strong suspicion of traumatic macrovascular hemolysis. Most cases arise in the setting of dysfunctional mechanical or severely calcified aortic valve. High pressure gradient across the irregular valve. High pressure gradient across the irregular valve cause shearing or passing erythrocyte, leading to intravascular hemolysis. Damaged erythrocytes that are not lysed in the intravascular space are generally destroyed by splenic macrophages, leading to concurrent extravascular hemolysis. Mechanical aortic valves often cause mild asymptomatic hemolysis. However, valve deterioration can trigger symptomatic anemia, fatigue, dyspnea with exertion, with signs of erythrocyte lyse, jaundice, dark urine, reticulocytosis. Thrombocytopenia can occur because platelets may be damaged as pass through the rigid valve opening. Hepatosplenomegaly can develop as the fragmented erythrocytes are cleared in the macrophage and monocytes within the livers and spleen. Peripheral blood smear generally show schistocyte. A transthoracic echocardiogram should be performed to visualize valve function and determine the valvular pressure gradient. Okay. Yes, it looks like here is a, okay. So this patient with two recent episodes of pneumonia and splenomegaly, anemia, thrombocytopenia, and mild leukocytosis, and peripheral blood smear evidence of a leukocyte with an hairy cytoplasmic projections, suggesting the diagnosis of the hairy cell leukemia. Suggesting the diagnosis of the hairy cell leukemia. Hairy cell leukemia is a chronic B-cell malignancy that occurs primarily in age more than 50. Manifestation arise due to neoplastic infiltration of the bone marrow. Neoplastic infiltration of the bone marrow, spleen, and peripheral blood as follow. Bone marrow infiltration can cause bone marrow fibrosis and cytopenia. This can lead to recurrent infection, granulocytopenia, bleeding or bruising, or fatigue or weakness. Splenic infiltration causes splenomegaly. Mass effect may lead to symptoms of abdominal fullness or early satiety, gastric compression, and peripheral blood infiltration. Peripheral blood smear may show abnormal circulating lymphocytes with hairy cytoplasmic projections. Although most patients are leukopenic due to bone marrow infiltration. A minority, such as this patient, have mild leukocytosis due to increased circulating lymphocytes. Here is a leukemia does not typically cause hepatomegaly, lymphadenopathy, or B symptoms. Diagnosis require bone marrow biopsy with flow cytometry. Okay.